we are going to move on to our next speaker, who is a true expert when it comes to taking care of one of the most crucial yet often underappreciated parts of our bodies, our feet. With more than 15 years of experience as a dedicated podiatrist, Jessica Spence's journey has been a remarkable exploration of biomechanics, sports rehabilitation, and a profound understanding of the impact of autoimmune diseases. Jessica's podiatry journey began in the world of biomechanics and sports, where she honed her skills and understanding of the intricate mechanics of the human foot. Her dedication led her to work in a center specializing in neurological rehabilitation, where she collaborated with a wide or diverse range of patients grappling with biomechanical and orthopedic challenges. Today, we have the privilege of delving into the world of feet with Jessica Spence. Her profound insights on all about feet promises to enlighten us on the crucial role our feet play in our lives and how to care for them to ensure our mobility and comfort. Ladies and gentlemen, please join me in giving a warm welcome to Jessica Spence.
Thank you so much, Matt, for that very, very kind and generous introduction. I'm very excited to be with you all this afternoon. And let's jump straight into it. I'm going to share my screen quickly. Can you see that, Matt?
Yes, yep, we've got it.
We've got it. Okay, perfect. I'm very excited to be sharing this afternoon. We're going to be talking through axPAR and the foot, and the discussion topics for my talk are going to be what is a podiatrist, and then we're going to discuss psoriatic arthritis in the foot, AX in the foot, and then essentially what does a podiatrist do and what can we do for you. So let's just start off right from the beginning. What is a podiatrist? Podiatry is a branch of medical services that's dedicated to the study, diagnosis, and treatment of lower limb pathology. So we basically do all things lower limb, and that includes anything dermatological, biomechanical, neural, orthopedic, radiological, anything that happens with the foot, the lower leg, we are trained to diagnose it and treat it. And if we don't know, or if we're not able to treat it, we know exactly where to send you. And that's really important to know. Podiatrists are first-line practitioners. If you've got a sore foot, a sore ankle, a sore heel, a sore leg, a sore knee, then you should be seeing a podiatrist first, rather than your GP. This is where we start. All right, let's talk through psoriatic arthritis and the foot. Okay, so as we all know, we're going to cover three things in our psoriatic arthritis discussion. We're going to talk through psoriatic arthritis in the foot, how it affects the foot. We're going to look at dermatological and other manifestations of the foot. All right, so as we know, psoriatic arthritis is a systemic and chronic disease that affects many aspects of the body. It's an inflammatory condition with many, many clinical manifestations. That includes nail psoriasis, it includes peripheral joint disease, axial joint disease, enthesitis, and dactylitis. And I know those are lots of big terms. Don't worry, we're going to come to them. We're going to break them down into easy to understand items. So psoriatic arthritis is inflammatory in nature, and essentially it affects the linings of joints and tissues. This causes inflammation, and we're going to discuss this inflammatory cycle. This is essentially how psoriatic arthritis affects our feet specifically. This is how it relates to that. So we have inflammation. Psoriatic arthritis causes inflammation, which causes a rise in sort of hormones and all those little cytokines, which causes swelling of the structures. Okay, so we've got swelling of structures. This causes swelling within the structure. So within your joints, there's swelling, and this is going to cause disarticulation of the joint. And I actually just want to switch on my camera for 1 second. I can't do that. So it causes disarticulation of joints. So what that means is that joints can't actually move nicely against each other. So your joints are like, picture two Lego pieces sitting together. And those suddenly, when you have this inflammation, you have the thickening of the structures, there's edema, there's swelling, suddenly those two Lego pieces don't want to sit nicely together. And that becomes problematic, and it leads to bony issues. Give me 1 second. Sorry, guys. I just want to make sure. Can everybody hear me?
Yes, we can.
Okay. Sorry, guys. A little bit of a technical issue there. Let's go through back to our inflammatory cycle. So those two Lego pieces are not communicating nicely with each other. And then we have this bony issue. These bones are not sitting nicely together. And what happens when our Lego pieces are not sitting nicely together? You have more inflammation. So we have a bony issue, we have inflammation, and combined, when those two things get together, we get a destruction of the joints. Our joints are destroyed. They're not sitting nicely together. They can't move nicely against each other. This then leads to bony remodeling. So the bone itself actually takes on a new shape. And imagine you've got a sort of broken Lego piece and a normal Lego piece. And now you're trying to fit those two Lego pieces together, and they don't fit nicely. And then that causes more inflammation. So we get into this very, very vicious cycle. And we see this happening with feet a lot. Essentially, what happens is this inflammatory cycle leads to a loss of function. And obviously, if you have a loss of function, it means that you can't operate nicely. And that makes it difficult to move. So that is tricky. And that's why podiatrists are so important. We want to try and maintain this function. Typically, psoriatic arthritis is asymmetrical. So we tend to see more issues on one foot than on the other. This is a nice X-ray. And this just shows us, if you look at that big toe, you can see that sort of middle joint there. You can see there's lots of little punched out areas. It looks like there's little holes in there. It looks like you've got weird little spurs and more bony lay down where there shouldn't be. And that's essentially what's happened in this patient, is that there is inflammation that leads to those joint spaces. You can see those joint spaces are too small. There's not enough space in between the joints. Those two Lego pieces are not going to be able to move nicely against each other. And what happens is you've got deformation. This patient's got a deformed hallux, their big toe. And if we can't move our big toe nicely, it means we can't propel ourselves when we walk. If we can't propel ourselves when we walk, it means it's more difficult to walk. So this is a typical example of what happens with psoriatic arthritis. Right, what are we going to be seeing? Manifestations. The first thing I want to say to anyone with axSpA is that foot pain is not normal. Every single one of my axSpA patients comes in and we're dealing with something else. And I say to them, well, do you have sore feet? And they say to me, yeah. And I say, well, that's not normal. That's something that we need to look at. So foot pain is not normal, and it can be treated. So manifestations are diverse and often misdiagnosed. They are typically asymmetrical. So we tend to see them on one foot. One foot will be worse than the other. We've discussed foot pain. Often it'll be diverse. I've got a sore ankle. Sometimes the pain is in the heel. Sometimes it's in the arch. Sometimes it just feels like it's everywhere. That's unfortunately what happens. Stiff ankles is one of our primary indicators, is that patients with psoriatic arthritis are going to have stiff ankles. Your PSA likes to affect the ankle joint. We're going to have difficulty or discomfort when walking, pain on top of the foot because it also affects the soft tissue. So those tendons on top of the feet are tender and sore. We've got your decrease in range of motion. We've discussed that. As soon as those two Lego pieces aren't talking to each other nicely, there's going to be less range of motion. If there's less range of motion, you're going to have joints that locking joints. If your joints are locking, then they're not happy. And if we're not happy, then we can't move. And if we can't move, then our inflammation gets worse and we're back in that horrible inflammation cycle. Also get swollen feet. This is incredibly relevant. We're going to talk, also we got psoriatic nails. So this is often something that is diagnosed, well, not diagnosed, but often patients will come into the practice with a nail that looks like this. It looks crumbly, it's a different color, the texture's not right, it's not growing nicely. And this is often a patient with psoriasis, and they may not know at this stage that they have an arthritis, or you may have psoriatic arthritis and you're wondering why your nails look like this. It's because you have a skin manifestation. So this is what a psoriatic nail looks like. They can come in all shapes and sizes. So if you just look through that top row, we've got pitting, we've got white nails, we've got red little dots, there's crumbling, there's all kinds of interesting things that are happening with your psoriasis. And so it's often missed. Often, your GP is going to say, oh, well, it's a fungal infection, because it may look something like this. It may not be a fungal infection. It's probably psoriasis. The next very common manifestation that I want to talk through this morning is called dactylitis. And this is a sausage deformity of the toe. It's one of the most typical features of psoriatic arthritis, and it's a swelling of the digit, and it's determined by the involvement of lots of different structures: the subcutaneous, the flesh underneath the skin, the fibrous tissue, the tendons are involved, the joints are involved, and all of those things. It's very common. And if you have a look at that foot, you can see that left foot is very swollen. The whole foot is swollen, it's red, but if you look at that little pinky toe there, you can see that it's hot, it's red, it's inflamed, it's swollen. And this is what we call acute dactylitis. We generally refer to dactylitis as either acute or chronic, and I'm going to talk about that in a moment. But one interesting fact to note is almost 50% of psoriatic arthritis patients experience dactylitis. You can get it in the hands, but most of the time it's going to appear in the toes. Just want to see here. So here we've got, this is a typical acute dactylitis. So acute dactylitis is red, it's hot, it's tender, and it's swollen. You can see it looks big and puffy. It can have biomechanical triggers. So patients who are struggling to walk might be more prone to having a dactylitis because there are other mechanical things happening in the feet. This is often misdiagnosed. I read a case study about a patient who had, excuse me, I'm just checking that's for me. We had a patient who had this red, hot, swollen toe. They went into the hospital. It was very painful. And the on-call doctor thought that this patient had what we call osteomyelitis, which is an infection of the bone and an infection of the tissue. So this poor patient had biopsies done, had blood tests done. He was put on 3 different drips of antibiotics. He was in hospital for about 3 or 4 days, and they could not figure out why this patient's toe was not resolving, why there was no reduction in pain, why it was so inflamed. And then they had a specialist come in, and that specialist started to ask questions about fatigue, general pain, other skin manifestations, and it was eventually discussed that this patient actually had psoriatic arthritis. He was currently in a flare, and he'd developed a dactylitis. So this poor patient went home from hospital a couple of days later with some pieces of his toe missing. You can also have what we call a chronic dactylitis, when it's swollen, but it's not hot, it's not tender, and it's not red. So you just get the swollen toe, and this tends to be very common. So if you look right now, if you have psoriatic arthritis, look at your hands, look at your feet. Now, obviously, swelling is a component of psoriatic arthritis, but you might notice that you've got a chronic dactylitis. So it's really important, if you have a psoriatic arthritis, that you know the manifestations of your disease so that you don't end up going to hospital and having little bits of your toe cut off. All right, another manifestation we're going to talk about is plantar fasciitis, and this is incredibly common when dealing with axSpA patients. It's actually often considered a diagnostic marker. So if you're going to see your rheumatologist, if you're seeing someone in the know, they're going to be looking for plantar fasciitis. Your plantar fascial band is an incredibly thick band of tissue. You can see, if we're looking at that picture there, you can see that heel, that calcaneal bone, and you can see that little spur there, that little jutting out bit of bone. And then if you follow to the right, you can see that shadow, that strip of shadow, that's your plantar fascial band. It's an incredibly thick, incredibly strong band of tissue that's responsible for shock absorbing shock when you're walking, when you're moving. And that little enthesis there, that means where that bit of fascia meets the bone, where they join, that spur gets very, very inflamed. And plantar fasciitis is characterized by heel and arch pain, especially in the mornings. This patient climbs out of bed in the morning, has a terribly sore foot. By the time they've gone to the bathroom or made themselves a cup of tea, it actually starts to feel a little bit better. As the condition becomes more chronic, you may find that you get pain after rest, or you actually just get pain in that heel, in that foot throughout the day. And that needs to be treated not by your GP, but by your podiatrist. And there you go, a lovely little picture of that plantar fascial band. You can see where it's inserting in there. We call that an enthesitis. So where that fascia or that tendon meets the bone, we call that an enthesis. And that structure, that whole structure, gets very inflamed and very, very tender. You're also going to have Achilles tendonitis, which is another example of an enthesitis, which is an inflammation of that structure where that bone meets the tendon, where those two structures, the soft tissue meets the hard tissue, where your bone meets that soft tissue. That's an enthesis, and that's where we're going to get that irritation. Excuse me. And that's very, very common for axpar patients to get Achilles tendonitis. It's inflammation of the insertion. You actually get 3 different kinds of Achilles tendonitis. You get one at the enthesis, so where the bone meets the soft tissue. Then you're going to get a mid portion. So if you look at that second arrow there, that's sort of halfway up the tendon there. And then you're going to get a higher an irritation where the muscle actually becomes a tendon. And that is Achilles tendonitis, very, very painful. And this is going to also, it might exhibit as early morning pain, but this patient just tends to get pain throughout the day. You may have heel spurs. And what actually happens is, because you have psoriatic arthritis, what's shown is that these conditions are going to develop, is that psoriatic arthritis actually prevents these conditions from healing by themselves. So if you are experiencing plantar fasciitis or an Achilles tendonitis, you do need help. There you are. That's a lovely picture there. You've got your calf muscle, and you can see that tendon inserting into the heel bone. And you can see there's an insertion. If you look at the picture on the left, you're going to see an insertional Achilles tendinopathy where that tendon inserts into the bone. That's the primary site of an axpar or an enthesitis. Then you see a mid-portion Achilles tendinopathy. That's going to affect other people. axpar, generally an insertional Achilles tendinopathy. So if you take your fingers right now and you just pinch very gently that heel bone and all the way up the back of your heel there, all the way up there. If you've got tenderness there, that might be an insertional Achilles tendinopathy. That enthesis is tender and inflamed. All right, let's talk about AX and the foot. We're going to discuss how it affects the foot and what we actually need to be looking out for. So AX is a chronically inflammatory disease, also of the entheses. It also affects the synovial linings, synovial membranes of your joints, your tendons, and your burses. Often we have patients who have axpar, or before they're even diagnosed with axpar, who have bursitis. A bursitis, often we're going to get it in the hip, on the outside of the hip there, because those cytokines, because all of those inflammatory issues are happening in your joints, tendons, and bursa, you're going to be far more prone to getting a bursitis, which is quite interesting. It obviously affects the spine, the sacroiliac joint, but also your peripheral sites, hands, but lastly, your feet. Right, let's talk about the inflammatory cycle in AX. It's slightly different to our psoriatic arthritis cycle. So you're going to start off with inflammation in the synovial membranes as a result of your AX. This causes bony proliferation. This inflammatory issue causes proliferation. And that means that there's an increase in bony turnover. The bone is putting down new bone. It's laying down new bone, but it's not in logical, normal sequencing. It's laying down bone in funny places. It's inflamed, it's hot. There's issues within bony formation. You then go through a period of ankylosing where that fusion happens. So you have this production of strange bone that then fuses. And we're going to then head over to joint deformity. Picture your two Lego pieces. One Lego piece that's a bit smushed. It's been left out in the sun. It's swollen. It's hot. And now suddenly you're going to try and put those two Lego pieces together, and they're not going to fit. If they can't fit, you have joint deformity. If you have joint deformity, it means that those joints can't move nicely against each other, which are joint articulation issues. That means that the joints can't move nicely. And as soon as that happens, you're going to have inflammation. And you're going to just head off into this really, really difficult inflammatory cycle. And what tends to happen here, as with your psoriatic arthritis, is you end up with a loss of function. And this affects more than a third of your AX patients. Let's look at that lovely picture there. If you look at that X-ray, if you look at the leg bone coming down looks healthy. You can see that cortical, that little bit down the middle, looks white and clear, and then you can see the outline of the bone is sitting beautifully. As you get lower, you can see that actually the bone density gets thinner in places, and you can't see joints clearly. Now, this is an interesting view that they've done on it, but those joints are not nicely defined, and that's that proliferation. The bone is interesting in a weird laying down of new bone. It's irregular. It then ankyloses. It's fusing in weird places, and you get terrible joint deformity. And this patient is going to struggle to walk. This patient is going to have real ambulation problems. And as we know, as Corné was talking about, movement is essential. If you can't move, we're going to really, really struggle with this disease. So this poor patient has really struggled. You can see there's joint space narrowing. So if you look at that X-ray there, you're going to see there's no, if we look at the bone, the leg bone coming down, meeting at that ankle bone, you can see there's a space between the two bones. As you move to the rest of the foot, those spaces are few and far between. Those bones are touching each other. It means those Lego pieces are deformed. They're not communicating nicely with each other, and this patient is going to have a problem there. You can also see this patient's got a spur on the heel. This person also probably has a little bit of plantar fasciitis. Let's have a look. All right, manifestations. What are we going to see? We're going to see midfoot swelling and pain. So your AX likes your midfoot. You're going to have a lot of pain. Why? Because there's that bony reformation. The joints are malformed. There's deformity, and there's no articulation. There's lots of swelling. There's a lot of swelling within this condition. There's heel pain, that plantar fasciitis, pain in the morning, after rest, swelling again, just because. Obviously, it's important. And this leads to difficulty, discomfort, and pain when walking. If you look back at this X-ray, this patient's not going to be happy when he or she is. All right, there's plantar fasciitis again. There's another picture of that spur there. Yeah. So now we've come to the most important part of this discussion, and that is, what can a podiatrist do? What do we do? If 30 to 70% of people with axSpA have foot involvement, and that's what the statistics say, podiatrists are essential. I want to remind you, if you are sitting here with untreated foot pain, there is an answer. You need to be seeing a podiatrist so that we can have a look and see how we can interfere with those inflammatory cycles there. Because podiatrists are first-line practitioners, you're often going to have, we've had before, patients who come in with Achilles tendinopathy, with a plantar fasciitis, who complain of terrible fatigue, terrible joint pain, and we are sending them to the rheumatologist, and we are getting positive diagnoses of axSpA, of psoriatic, of rheumatoid. So seeing your podiatrist is absolutely essential. Our job is to ascertain where in the cycle you are. Those 2 inflammatory cycles that we looked at. Where are you in the cycle, and how can we come in at that point and intervene to stop that inflammatory cycle? Our main goals are these. We want to maintain your movement, we want to decrease your pain, and we want to protect you going forward. How do podiatrists do that? Our job is to decrease the load on the joint. We want to maintain mobility, but we want to reduce the stress on that joint. We want to increase shock absorption. If we can increase shock absorption, we can also decrease the load on the joint and on your soft tissue structures. And we want to diagnose and treat any present conditions like your Achilles tendinitis, like your plantar fasciitis. These are really, really important. If we can do these three things, we can reduce inflammation. And let's talk about this maintenance cycle. Our job is to reduce inflammation. If we can reduce inflammation, we can slow down or limit joint destruction. If we can limit or reduce joint destruction, we can reduce your pain. If you are in less pain, we can make sure that you keep moving. That's so important. If we can keep you moving, we're going to reduce inflammation. So this is really important. This is where your podiatrist wants to come in. This is what we want to do. So we want to take you out of that inflammation cycle, and we want to put you into a maintenance cycle. We want to slow down or prevent any decay, and we want to, if possible, improve your function, reduce your pain, and keep you going. There are a couple of ways that we do that. Typically, we're going to talk about shoe wear. That is incredibly important. Technology has advanced significantly in the last 10 years, in the last 5 years, in the last 2 years, but shoes are essential to managing and maintaining patients who have axSpA. Just by putting you in a proper pair of shoes, we can reduce that joint load, we can increase your shock absorption, and we can treat any foot issues that we have going on. Wearing a correctly fitting shoe is essential to maintaining your movement and your good outcomes. If you are wearing a slop, if you are wearing a sandal, if you are wearing a pump or a court shoe or a heel for most of your day, even if you're barefoot for most of your day, you will be in that inflammatory cycle. Even if you're not experiencing huge amounts of foot pain, you are already in that cycle. Shoe wear goes a long way to intervening and getting you into a maintenance cycle. I tell all of my axSpA patients that they must have a good pair of tackies. Tackies are absolutely essential. I tell my patients with axSpA, if you have axSpA, you should be wearing a tacky for at least 4 to 5 hours of your day. And it's a game changer. Patients always come in a lot of pain. We put them into a pair of tackies, and suddenly the world is a completely different place because you can move better and you have less pain. Consistency is key. Obviously, if you're wearing a tacky for 1 hour and then you're wearing a high heel or a pump or barefoot for the rest of the time, that is not effective. Consistency is key. The next thing we do are orthotics. So orthotics are incredibly important when we are managing axSpA patients. If you have a look at that picture, you're going to see that little blue thing underneath the patient's foot. It may look simple, but an orthotic is able to change the direction and the position of your joint. If we can change joint position, and if we can improve shock absorption to that joint, we're going to immediately head off into that maintenance cycle. And that little joint is going to affect the next joint, which is going to affect the next joint, and it's just going to mean that your whole mobility cycle is improved. We support arches, we support your soft tissues, we support joint structures. An orthotic is designed to support your foot, to improve functioning. And it's an absolutely essential part of reducing stresses and improving your lifestyle, improving your lifestyle, improving your pain, reducing that inflammation, getting you moving. If our goal is to keep you moving as pain-free or with as little pain as possible. As Corné was talking about, that the robot, shoe wear, and orthotics are going to play an important role in figuring out where are you in your pain robot. Are you green? Are you orange? Are you red? And hopefully with orthotics and the correct shoe wear, we can actually move you to the correct position. We can move you to an orange. We can move you to a green. We want to keep you moving. And if the association has its way and Axpa does become a prescribed minimum benefit, we're really hoping that seeing a podiatrist becomes part of a prescribed minimum benefit option available to Axpa patients, because it drastically improves patients' lifestyle and their outcomes and their ability to keep moving. Thank you so much for letting me be a part of this journey, and I hope that you enjoyed that.
Thank you so much, Jessica. That was a wonderful presentation. I know myself, I went through a little bit of plantar fasciitis about 10 years ago, and it was not a pleasant experience. Luckily, my feet are all good now, but I know a lot of our patients do struggle with it from time to time.